So let's go to some bottom line points when it comes to CPAP and OSA. So talking about CPAP adherence. So early CPAP adherence establishes long-term use, which means that they got to have a good first impression on CPAP. And that's why when people come to the hospital, and one of the reasons why we don't do in-hospital sleep studies or slap CPAP on people when they're recuperating from their CHF or something else, they may have a bad first experience, It's important to realize there's no difference in CPAP adherence for people with mild OSA compared to moderate or severe. I always thought that, there would be a difference, but there's not. And behavioral, supportive, and educational interventions definitely improves compliance. Behavioral interventions improve compliance by 1.2 hours a night. That's amazing. Supportive interventions such as automated phone calls, improves compliance by 0.7 hours per night. That's pretty impressive. And of course, watching a video educational intervention improves it more than half an hour a night. So all these are definitely going to improve compliance. Interface. So whether you use the intranasal, you call that the nasal pillows, or the one that goes over the nose, there's no difference. But there's definitely an improvement with adherence when you use any type of nasal mask over a full face mask. So that's going to be important to try to get this, even though we both know that there's, mouth breathers and you can't do it for everyone. Hypnotics. This was a very interesting study that occurred when I was during my fellowship, where zopiclone, I believe that's Lunesta, at the top dose, which is 3 milligrams. You give it 14 days. That improves adherence with their CPAP device. And it's probably because it's giving that reassurance that they could fall asleep. Do we do it on everyone? The answer is no, but something to consider. And heated humidifier, I think the thing that I wanted to pound home is that there's no improvement in regards to compliance, but it definitely makes the patients feel better and they won't have the dry mouth. So let's talk about CPAP and the impact on clinical outcomes. These are bottom line points. So what is the optimal amount of CPAP to use? Well, it really depends upon what outcome are we talking about here. But of course, the more you use CPAP, the better it is. And of course, if they're going to be taking a scheduled nap during the day to put them to wear the CPAP, of course, this is why, travel CPAPs are so popular right now. And of course, one of the reasons why we initiate CPAP on some individuals is because of high blood pressure, hypertension. And there have been studies that show a reduction in 24-hour mean blood pressure when you're being treated with CPAP. Now, to be honest with you, the blood pressure lowering effect is greater in those who have excessive daytime sleepiness. So in any disease state we're talking about, when is CPAP going to be beneficial for the boards? It's especially if they're sleepy. So those with excessive daytime sleepiness and have something called refractory hypertension. And refractory is definitely worse than having resistant. Refractory is the worst. And in non-sleepy OSA patients, the effect of CPAP still remains a little bit unclear. So in non-sleepy adults, talking still about the impact of clinical outcomes, in non-sleepy adults with moderate to severe OSA, this is an HI above 15, CPAP does not prevent primary or secondary cardiovascular events as seen in randomized controlled trials. But of course, a lot of people who are in these trials were using the device, the CPAP, less than 4 hours. So it still remains in debate about, really pounding home compliance. What happens if you're using it more? But as of right now, when we talk about using CPAP, you just don't have the data to show it prevents primary or secondary cardiovascular outcomes. Good question for the boards. In the cardiovascular inpatient, that's the key word, is inpatient population, CHF, arrhythmias, and MI, patients with OSA, CPAP initiation and compliance may decrease readmission rates. So of course, this is one of the things that we want to, try to get out there or schedule them for a in-lab titration the minute they get discharged. It's very hard to get reimbursements for in-lab titrations and in-lab diagnostics when you're an inpatient. Unfortunately, there's limited and sometimes conflicting data regarding mild OSA and cardiovascular outcomes. I kind of mentioned that already. Other outcomes, CPAP is not associated with weight loss. Just putting on CPAP doesn't guarantee you're going to lose weight. CPAP is associated with a reduction in motor vehicle accidents. I totally believe that. And there's inconsistent results regarding what happens if you use CPAP in regards to your diabetes, hyperlipidemia, and metabolic syndrome. So what are going to be the strong recommendations of the American Academy of Sleep Medicine in regards to initiating CPAP for OSA? So I would say use CPAP to treat OSA in patients with excessive daytime sleepiness. Use either CPAP or AutoPAP for initiating or ongoing treatment. So if someone has OSA, it's great for initiating as CPAP or AutoPAP. Definitely implement educational interventions with PAP initiation. Use PAP to treat sleep-related quality of life or comorbid hypertension. We mentioned that there is data for hypertension. Of course, sleep-related quality of life, if you're sleepy during the day, use CPAP or AutoPAP. And behavioral implementation or telemonitoring guided interventions will definitely improve compliance.